This program is brought to you by Emory University.
All right, so we'll be talking about SVT today, and we'll try and go over, well, I'll tell you what we'll go over. So there's a lot of different words thrown out about arrhythmias that involve the atrium or come from the top chambers. There's AFib, atrial flutter, PSVT, PAT, AVNRT, WPW, JET, ORT, AVRT. So a lot of different letters and abbreviations that are thrown out. But today we're going to focus on AVNRT, atrial tachycardia, and ABRT. And we'll go through the mechanisms for all of these, some of the EKG findings, which is mostly what we'll focus on. We'll touch on what you see on EP study and then management. So we'll try and cover these for these three particular arrhythmias. AFib and A-flutter are certainly tachycardias that are initiating in the atria, but those aren't really what we consider to be paroxysmal SVT. So when you encounter a patient, you can get a hint at what their SVT might be based on their age. So they tend to change as age goes on. AVRT is most common in younger patients. It's rare to see atrial tachycardias and AVNRT in younger patients, although you certainly can, and become less common as people age. AVNRT takes up the bulk of SVT and certainly increases as people age. And then atrial tachycardias are the least common, and but depending on the substrate and the comorbidities in a particular patient, it might be your most likely etiology, but it takes up less and less as younger patients and more as people age. So in my cartoon, thinking about the different tachycardias, atrial tachycardias initiate from a focus within the atrium. It can be the right atrium or the left atrium, and there are different mechanisms for atrial tachycardias like there are for ventricular tachycardias. We think of the three basic mechanisms as reentrant, automatic or increased automaticity, and trigger. But whatever the mechanism, you have a focus that's firing, and then it'll get down to the ventricles depending on the AV node conduction. So it can be in a 1-to-1 or 2-to-1 fashion depending on how much the AV node can handle. AVNRT, the basic mechanism for it, is that you have two pathways to get down to the AV node. And this is not uncommon. In different series, it's anywhere from 10 to 30% of people will have what we call dual node physiology. So it's not abnormal, it's a variant. And when I draw them or where you see it depicted, it sort of looks like it's going just straight down from the atrium to the ventricle. But if you look at this other picture that's more anatomically correct, it's actually two inputs to the compact AV node, and it's sort of, the atrium is sort of on its side. And so the fast pathway tends to be more superior and the slow pathway is inferior and more posterior. And so when I draw it sort of upright because that helps me think about it, but anatomically it's more on its side. And so that affects where we ablate if you're ever in a case. So the mechanism of AVNRT, the reason one is called fast and one is called slow is that the one can conduct the signal more rapidly. So the input will usually go down the fast pathway because it can conduct more rapidly, but it becomes refractory more quickly than the slow pathway. So if you have an extra beat come in, then the fast pathway is more likely to become refractory first. And so if you have a PAC come in that's timed close enough after the prior beat, the fast pathway will be blocked, it'll be refractory, and so the signal will go down the slow pathway. By the time it's gone down and around, the fast pathway has now recovered, and so the signal can go up the fast pathway, and then you get caught in this reentrant rhythm between the fast and the slow pathway. So that's the mechanism for AVNRT. And then lastly, with WPW or AVRT, WPW, these are all, AVRT is the better phrase for it. WPW is when you have evidence of pre-excitation on EKG, and you have a WPW syndrome is when you have WPW pattern plus tachycardia, but it's ABRT is sort of the more encompassing term, and it relies on the presence of an accessory pathway. And when we're in utero, we have a lot of connections between sort of in the perivalvular area between the atria and the ventricle, and those should all be gone by the time we're born, and some people are left with an accessory pathway. So the signal from the atrium to the ventricle can go down the normal AV node to His bundle, but can also go via the accessory pathway. And so similarly to the onset of AVNRT, you have a premature beat coming somewhere, and that often will block going down the AV node. And so there are two options. One, it can block going down the AV node. You can go down the pathway and up through the AV node by the time it's recovered. That is when we use the AV node is the retrograde limb. That is antidromic reentrant tachycardia. So that's when you get the wide complex tachycardia because you're going down the pathway. So the ventricle is being activated through the pathway, so it's wider, and then up the AV node, so that's antidromic. More commonly, you have orthodromic, where you're using the AV node as the down path and then the accessory pathway as the retrograde limb. So that would be ORT, or orthodromic reentrant tachycardia. But these all are reliant on something coming in early such that one limb of the tachycardia is blocked and then recovers in time to conduct in the other direction. So that's the mechanism of ABRT. So those are the three we're focusing on. And then when we're looking at an EKG or somebody presents with SVT, here are some things that we look at on the EKG or on our tele strip or whatever, our monitor, whatever we have. So it's important to identify the P wave. One thing that we look at is what the P wave looks like compared to sinus rhythm. Sometimes the tachycardia is sinus tachycardia, and so it's important to identify the P wave compared to the baseline. You don't always have that luxury, but we often do. Looking at the onset and offset of the tachycardia is helpful. The initiation is often with a premature P wave, and so again, that's leading to block somewhere, which allows for the reentrant tachycardia to ensue. We also will talk a little bit about AVNRT and what we see on EP study, which will help understand what we see on EKG. But when you often have onset, you have a PAC plus what looks like it's a critical prolongation of the PR interval, and then you have onset of tachycardia. So the onset is helpful. So if you're on service and you have an SVT on tele, go back and look at the onset because that can help identify what's going on. Termination with the P wave essentially excludes atrial tachycardia. And what that means, that's if the tachycardia spontaneously terminates and it ends with a P wave, it is hard to explain why an atrial tachycardia would terminate at exactly the same time that you're getting AV block. And so if it spontaneously terminates with a P wave, it's very unlikely to be atrial tachycardia because that P wave should conduct to the ventricles. And so that's a clue that we look at as well. We look at the conduction pattern. So if you have a 2-to-1 pattern, then that excludes ABRT. And the reason is that in ABRT, both the AV node and the atrium are essential components of the tachycardia. So it cannot, there is no way that the tachycardia could be occurring if the conduction is not 1-to-1. So it's atrium, ventricle, atrium, ventricle. So if it's a 2-to-1 pattern that excludes ABRT, you can see block with AVNRT, and that's unlikely. We do see it in the lab. I would say it's not completely infrequent, but it's unlikely to clinically present with 2-to-1. So 2-to-1 would be much more suggestive of either flutter or an atrial tachycardia. We look at the RP interval, and we'll talk about short, intermediate, and long RP tachycardias in a second, but that one is really, it's important to understand the mechanism for these tachycardias to understand why the RP interval is so important. And then lastly is response to adenosine or vagal maneuvers. So adenosine, we know, terminates AVRT and AVNRT. The mechanism is that it decreases calcium influx and it activates potassium channels. It hyperpolarizes the membrane, it slows conduction velocity in the AV node and slows the sinus rate. It does not affect the His-Purkinje conduction, and it, in a general sense, does not block conduction in accessory pathways. And so if you have an atrial tachycardia, for example, and you give adenosine, there are some atrial tachycardias that are adenosine sensitive. We put the number at about 15%. And so if it responds to adenosine, it doesn't completely exclude atrial tachycardia, but what you'll often see is the atrial tachycardia continuing as you get AV block. If it terminates with adenosine reliably, then it's often AVNRT or AVRT. And just keep in mind that adenosine can precipitate AFib. It shortens the atrial refractoriness, and so you can see AFib after adenosine, and technically you can see VFib as well. Okay, so here are some examples of the AV relationship. So these two top ones are 2-to-1 AV conduction. So we know it's not AVNRT, most likely not AVNRT and not AVRT. And you know, you got to be careful to look for the P waves. And so here we have a P wave, and then here we have a P wave. Often the rate of the atrial activity will suggest atrial flutter versus atrial tachycardia. Atrial flutter, the P wave, the atrial cycle length is often 250 to 350 beats per minute. And so when thinking about the mechanism, if it's an AT or a atrial flutter, that's we look at the atrial rate. And then this is versus this bottom strip, which is 1-to-1 conduction. And so this would be more likely what we call this SVT category. And in this particular one, we see these P waves at the end of the QRS. And so this one would be most likely AVNRT, but we'll get into that in a second. Okay, so sometimes it's hard to tell the P waves, and that's where it's always helpful to compare it to sinus rhythm. And when we're thinking about AVNRT, again, I'll get to the mechanism, how it relates to this in a second, but it's often buried at the end of the QRS. And so if we look closely, we see here in V1, we call it sometimes a pseudo R prime. Now in this one, she actually, you know, it's sort of after that R. And we look closely in 2, and you see a little retrograde thing here. Okay, so talking about the RP interval. So a short RP interval is, and it depends how short, but it's the short one when it's right at the end of the QRS is either AVNRT, or it could be atrial tachycardia with a long first-degree AV block. But this cannot be AVRT. So the short RP tachycardia is AVNRT or atrial tachycardia. The long ones where you see this discrete long PR interval can be atypical AVNRT. That is when instead of going down the slow pathway and up the fast pathway, you're going down the, wait, hold on a second. Down the slow and up the fast, you're going down the fast and up the slow. And so we will, that one can be atypical AVNRT, can be a long RP tachycardia. Atrial tachycardia and WPW or AVRT can be long, and then mid are more likely to be WPW, can also be atrial tachycardia, again, depending on the conduction of the AV node. So that's how we think of them. So the short ones, AVNRT, that when we have it really right behind the QRS, and the atrial tachycardia can be there as well with that long first degree. And then the mid ones often more likely are WPW. All right, this is an EKG just showing WPW pattern. And so I know you guys have all seen this, but what you're looking at is this delta wave, which represents the part of the ventricle that is being pre-excited via that accessory pathway. So this is WPW pattern that you'll see. And some things to keep in mind about WPW is accessory pathways may conduct very fast. And so that's why you see this threat of pre-excited atrial fibrillation, where there are no brakes on conduction from the atrium to the ventricle. And not only can they conduct rapidly, so if atrial fibrillation were to occur, you could develop VFib related to that, but people with WPW are prone to atrial fibrillation. And so they tend to have more rates of AFib. Okay. So before we get into some cases, I want to go over what we see in the EP lab, which again, I think helps sort of understand why we get these short, mid, or long RP intervals. So we'll go through this slowly. These top channels are the surface leads. So these are the P waves and QRS. HRA stands for high right atrium. So this is a catheter in the right atrium. HIS stands for catheter at the level of the HIS bundle. So on this one here, you can see when you're measuring the HIS signal, which is right here, you see atrium, ventricle, atrium, HIS, and ventricle. So that's all on this channel. And then CS is in the CS, or it goes the way that we often do it, it's straddling from the right atrium across through the CS. So you get right atrial and left atrial signals. And so if we look at these first 1, 2, 3, 4, 5 beats, what you see is AHV, 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 and then this is an early atrial stem coming in. So when we were talking about the fast and slow pathways, the pathways again are going to the compact AV node in the HIS bundle. So we're measuring from the A to the H. That is where you see pathway activity. So these shorter AH intervals are due to conduction down the fast pathway. If you have a beat come in very premature, that fast pathway could be blocked, and then it takes from here all the way to here to get to the HIS bundle. So now it's going down the slow pathway. Again, because that fast pathway, it conducts the signal faster, but it blocks quicker. So it's off the fast pathway, it's going down the slow pathway. By the time it's gotten to down to the bundle of HIS, the fast pathway has recovered, and it can now go backwards up through the fast pathway. So the reason that you get such a short interval here is because you are activating the atrium and the ventricle. What we talk about, you're activating them in parallel. So it's not, it's whipping around this reentrant circuit between the fast and the slow pathway, and it's activating up to the atrium, down to the ventricle pretty simultaneously. And that's why you have such a short RP interval, or a VA interval as we would refer to it in the lab, because this is the atrium being stimulated from that circuit, and this is the ventricle being stimulated from that circuit, and they're being stimulated pretty simultaneously. And so we get this really short interval between the V and the A, or if you're looking at the EKG, the R and the P. And then the tachycardia continues here. So you're going down the slow pathway, and then you're going up the fast pathway. You're doing that circuit, you're activating the atrium and the ventricle pretty simultaneously. So that explains why you get this really short RP. And that's, if you were to change the sweep speed here, you would probably be more able to see, here's that retrograde P wave that you're seeing here. And the P waves are they're being activated from low, from the HIS bundle, to high. And so you get a negative P wave in your inferior leads because it's being activated from low to high, negative, or sort of backwards. And so you get this inverted P wave. Okay, so that's what we would see on EP study. And again, you're activating the ventricle and the atrium in parallel. And so you get this really short RP time. And that is different than what we would see on EP study for ABRT. So remember, in ABRT, we're coming, and this is a strip, this is ongoing ABRT, and I'm not going to get into the development of the left bundle here, but if we look at, again, our intracardiac catheters, HRA, the high right atrium, and then the HIS bundle and the CS. I've put on over here, this is what it would look like in the lab. So this is our CS catheter here. And so this is an LAO projection. One is fairly out the coronary sinus. So this is left atrium. So when we go back here to the tachycardia, we have A, H, V, and then this is how it's getting back up to the atrium. The first atrial signal that's activated is CS1-2, which correlates to this thing way out here in the left atrium. So usually when a lot of people have conduction from the ventricle to the atrium, but you're usually breaking out, the normal conduction is up through the septum, right through where the His bundle and AV node is. And so in a normal person without an accessory pathway, your earliest atrial activation will be at around 3, 4, or 5, 6, which is where the septum is. So the only way to be activating 1, 2 earliest is if you have a bypass tract or an accessory pathway. And so because in ABRT, you're going down the AV node His bundle, down to the ventricle, and then up through this bypass tract, and then the atrium's being activated. That's why you get a mid RP. That's why your timing from the ventricle to the atrium is longer. In ABRT, it's being activated in series. So it's first ventricle and then atrium, ventricle, then atrium, and it's not that simultaneous activation, and it takes time to get through the His-Purkinje system to the ventricle and then up to the atrium. So that's why your P wave is going to be more mid tachycardia. Okay. And then this is an example of an atrial tachycardia where you have some focus somewhere that's firing, and your time from your P wave to your QRS will depend on how robust the AV node conduction is or where the focus is. But it's if you have a very long conduction from the atrium to the ventricle because either His-Purkinje disease or AV nodal disease or just normal, you can have a very long PR interval, which if we talk about the RP interval, it can really be anywhere depending on how someone's conduction is. So that one doesn't depend on the mechanism so much as what somebody's AV node does with the atrial signal. Okay, any questions about those? Okay. All right, so here is I'd like somebody to help with this one. So which one in between these two is more likely to be an atrial tachycardia? And ignore, well, I don't know if the arrows help, but.
Hey, Dr. Westerman, it's Evan. I think on the, it's kind of small, but I think on the left, I see P waves, at the like, terminal P wave at the end of this rhythm cycle. Whereas on the right, I don't see a terminal P wave, which makes me think that the right one would most likely be an atrial tachycardia.
Yeah, exactly. So this will be one where we're in rounds and we say, what can this not be, or what is this one more likely to be? And that's right. And it's hard sometimes to tell what's the P wave and what's the T wave, but you see very clearly there is activity here that you don't see after termination. And so that's right. So this one is more likely to be the atrial tachycardia. And this one does look pretty classic for that short RP tachycardia, and it terminates with a P wave. So unlikely to be atrial tachycardia. Okay, good. All right. So how do we treat SVT? So acutely vagal maneuvers, which slow conduction through the AV node, and the ABRT and AVNRT, they both are relying on AV node to persist. And so if you slow down that connection, you can terminate the tachycardia. So vagal maneuvers, adenosine, and then you can give beta blocker and calcium channel blocker. It is found that adenosine works quicker. And oftentimes, if somebody's hypotensive, then you don't drop the pressure like you might with beta blocker or calcium channel blocker. In the long run, ablation is recommended for AVRT and AVNRT. But if somebody prefers, you can do beta blocker, calcium channel blocker, digoxin, or some of the other antiarrhythmics. In general, when we have AVRT, even WPW pattern, it's not, if somebody has a high risk profession, those people should be studied, at least studied to sort of assess how dangerous the pathway is. And that has to do with how rapidly it can conduct. so that if atrial fibrillation were to occur, are they at risk of developing VFib from how rapidly the ventricle is being activated? Ablation, when we do ablate, so for AV NRT, and I touched on this before, we are ablating the slow pathway. Historically, when they first started, they ablated the fast pathway, and that led to a lot more AV block. And so we target the slow pathway, and that is generally an anatomic target in the lab, so we know where we're going, and that's how we do it. For ABRT, we're targeting the pathway, and I've drawn it on the left side, but obviously right-sided pathways occur. Also, some people have multiple bypass tracks. Okay, and then for atrial tachycardia, it depends on the substrate and the patient, but ablation is also pursued for ATs in some cases. Okay, so we're gonna get to cases. So these are participation, please. And okay, not the first one, I don't think, I don't know. So 53-year-old woman with recurrent palpitations, episodes terminate with cough or Valsalva, no history of heart disease, and presents to the ER with tachycardia. This is her EKG. And she gets adenosine and sinus rhythm is restored. See, the problem with calling on people is I don't even know if you guys are here, but I'm gonna try. All right, Errol, your name is up. Okay, I'm just gonna have to go. Dan, are you there?
Sorry, I got called out. One second, let me take a quick look here. So the rate looks like 150, but I'm not sure if I see retrograde P waves here. Adenosine restores sinus rhythm. I would say AV NRT.
Yeah, and this might be a little bit longer of that RP than we have shown on some other ones, but they're certainly inverted. So retrograde P waves, they're fairly close to the QRS, although I agree with you, it might not be as close as we usually see. But this one is most likely AV NRT. And with AV NRT, we often get a history where as people get older, episodes tend to be longer and less responsive to vagal maneuvers. So that's very typical when somebody, maybe they've been able to terminate before with cough or vagal at home, and then eventually that doesn't work anymore. Okay, this is a 26-year-old man with recurrent SVT. Okay, Dan, I've got your name here.
All right, so this is like narrow complex regularly, so SVT, and I see a small P wave just right before the QRS, so it should be like a short, I think it's a short a long RP, and it's young and terminated by adenosine, so AVRT for this patient?
Yeah, good. So this one, the clues really help us, the age of the person. And I think that these are probably the P waves here. So I would call this one it's hard to tell on these, what's P and what's T wave, but we see a hint of it here in V1 and certainly in V2. So I would call this one probably a mid RP tachycardia, and the age and the adenosine, that all help us. And so this one is a example of AVRT, just like you said. Okay, so this one you treat with adenosine. This is, what's this? What is this?
Pretty excited, I said.
Okay, good, yeah. So this is really, and this might be on your general boards. How would you, I'm not sure who answered that, but whoever did, how would you treat this?
Procainamide or ibutylite.
Okay, and what if they are hypotensive with a systolic of 60?
Just shock them. I would just shock them.
Right, yep. And so the problem with, why wouldn't you give AV nodal blockers?
So that will encourage more conduction to the accessory pathway and worsen it, and they will go into AFib. VFib.
That's exactly right. So those are all the right answers. Amiodarone, you would ask why not? Well, can cause hypotension. There might be some slowing of conduction through the AV node. So those are the exact right answers. Procainamide or ibutylide are the recommended drugs of choice, or if they're unstable, you just shock them. So if somebody is known to have antidromic reentrant tachycardia, and they've got a stable wide complex rhythm, adenosine in that case is not the same. It can sometimes be used effectively to terminate the rhythm. If there's any concern about it, don't use it. But it is really, sometimes you can use it. So it depends on the clinical situation, but certainly this, you would never give that. Okay. All right. So these ones, I don't have a stem on any of them, but we'll look at them. I'll show you both the tachycardia and then the sinus. And then if we're having trouble, then I can go ahead and give some of the background info. Okay, do I have a volunteer? John, are you there? Ricketts?
Yeah, I'm driving though. I can't look at my screen right now. I'm sorry.
I thought you were that good just to know. All right, Marvin.
Yes, I'm here. So it's a narrow complex tachycardia. Rate's about 150. I think it's conducting 1-to-1. It's not an ultra short RP tachycardia, but I think it's still in the short to mid range. I can see upright P waves in V1. Still can't rule out the others, but if I were to guess, if this was a young person, probably AVNRT, I would try to do adenosine and see what happens.
So I would argue that these are the P waves here on V2.
Yeah. Uh-huh.
V2. And so this one I would not call a short RP.
Okay, so
Very discrete from the QRS. It's certainly, if you looked at 3, you might get a little confused, but these ones I would call this a mid RP.
mid RP.
Yeah. And so it is a young person. It's a 27-year-old man who has recurrent palpitations, and he's just sitting in this on the floor.
Okay.
It does terminate with adenosine, but it's very incessant. And so the mid RP, the younger person, I would
AVRT.
Yeah, and so whenever you have ABRT, then you look at the baseline EKG to see if you have any evidence of pre-excitation. And in his case, you don't really see any delta wave. You don't see any slurring. That doesn't mean that you wouldn't have, that you can't have ABRT just because you don't have any manifestation of the accessory pathway on EKG. It's something that we call concealed conduction, or it might just not conduct antegrade. And so it's helpful when you do have the evidence of pre-excitation, but you don't need that in order to have ABRT. And so, but in his case, he did have a pathway, and his pathway was on the left side. And it also, interestingly, we could not get it to conduct antegrade in the lab. It only conducted retrograde. And so that's when, so you're in his tachycardia, you're coming down the AV node and then going back upwards through that pathway. Okay. All right. This is hard to see. So I got anybody? I see Grady Fellows. Maybe there's more than one person there. You guys can tackle it.
I think they have issues with microphone.
Okay. Evan, I'll take you again.
Grady fellows are responding in the chat box. Hold on.
Gosh.
They say question mark AVNRT.
Okay, good. All right, so here is this. So it's with AVNRT, when you don't see that really discrete, you know, the V1 is often where we will look first for that pseudo R prime. And it's real subtle here. And why it's pseudo R prime is because it's not the QRS, it's the P wave. But looking at her baseline, there is no blip in V1 versus here. So yeah, so this is a woman who she's a little bit of a mess, and I saw her in clinic many times, and she tells me she goes to the ER like twice a month for tachycardia, and she says they give me adenosine and it goes away. And I've been trying to get her. I never had seen the EKGs, and I don't know, I was a little skeptical, which maybe wasn't right of me. And I finally got one, and sure enough, I mean, she goes very rapidly. And so so it would be nice to try and ablate this, but she just keeps not showing up for the actual procedure. Okay. All right, so then Evan, how about this one? The stem on this one, this is a 58-year-old guy with pulmonary hypertension, and he is on, he has a Hickman for a continuous infusion of something. And he shows up twice to the ER with this, and this does terminate with adenosine.
Is it an AT that's adenosine responsive?
It is, that's right, yep. And so in this one, you might wonder, is this a 2-to-1? Does he have something here? I don't know, I would wonder about that at first, but this is a mid-RP tachycardia. It does not have any evidence of another P wave when it terminates. And so interestingly, and this is his sinus, so we ablated him, and he had this AT focus that was right where that catheter was. So I don't know if it was banging against the atrium and causing some, it's more likely that ones that terminate with adenosine are due to triggered activity or automaticity. So at first I thought maybe it was causing some scarring at that area, but it could have perhaps been some triggered activity from the, I don't know, from the line. But that's where it mapped to, and he hasn't had any more since then. So so that's right, an AT. All right, I don't even recall which one this is. Okay, this is another one of, so I'll go through this one. This is a 1-to-1. This one is perhaps a longer RP tachycardia, narrow complex. This is what the patient's sinus looks like. And so this has been on all his EKGs was called sinus tachycardia. But I think if we look at what his P wave looks like, so, you know, use all your leads for help. It's really quite a prominent upright P wave in 3, sort of in 3, 2, 3 in AVF. And so then when we look down here, even though perhaps V2 might look like his sinus, but it's very different in his inferior leads. And so he was a guy who was admitted, he has a structurally normal heart, was prior kidney transplant, and was admitted with a bowel obstruction, and he was just persistently in this. So this one I think is most likely an AT. Okay, this is an interesting case. So whoever would like, I'd like a volunteer, otherwise I can call again. But I'll give you this EKG, then we'll show you the next one. Did I see Nick's face on here? Nick, are you there?
Yeah, I'm here.
Okay.
Good morning. So this, I can see the P wave and the V1 somewhere in the mid RP to long RP range. So it's a narrow complex long RP tachycardia so far.
This is a 50, he's older, he's 60 years old and presented with this. Well, so what would be your guess on this, based on this?
Structure normal heart.
I believe so.
Yeah. I mean, if I had to, it goes at 150 as well. Maybe a little bit faster than 150. I don't see any evidence of pre-excitation, and maybe some sort of AT. I
Okay.
don't know.
So it's a, like you're saying, I would call it a mid-RP tachycardia. So the pre-excitation, if somebody is in ABRT and it's that orthodromic where it's going down the AV node and up the accessory pathway, you won't see pre-excitation because the activity of the pathway is not going antegrade. It's the retrograde limb. And so, but I think that's important to know when you see ABRT during SVT, it's going to be narrow complex. So I think that I agree. I mean, the guy's older. It's a 1-to-1. It's a mid RP. So we've got AVRT and AT on our list, and maybe AT might be higher based on he's never had tachycardia before, but he also does this.
Oh, I see. So that was an ORT then. Right?
Yeah. So this is the same guy. So what would you call this?
So this is a actually I forgot how it's called, but you see that typically when ORTs when they start conducting wide and narrow.
So you think that this is SVT, that this is still ORT, but now you've got some aberrant conduction?
Correct. Yeah.
Okay. It could be, but usually when things conduct with aberration, it looks like a typical something. So if it conducts with a left bundle, aberration or right, it'll look like a typical right or left bundle. This looks very bizarre. And in fact, this was called VT. What's neat about this one is you have tachycardia here. So this is a wide complex tachycardia. It terminates for a second. You have a relatively normal QRS. And then here we see that either this is just going to be 2 beats or could take off, but there's probably a P wave here that conducts with pre-excitation. So I think that this is the same as the narrow. He's got a pathway that can conduct in either direction. You're getting both antidromic and orthodromic tachycardia, one narrow, one wide. And so this guy ended up having, I don't think I've included his EKG. I don't even know if we had a sinus one until after he was ablated, but he had a left lateral pathway that conducted both ways. And so you saw both manifestations. You saw ORT and then antidromic tachycardia. But this one was a tough one. And it is the thing to keep in mind. And I have an example later on, which we may or may not get to, of what it looks like to conduct with aberration. So this one is very bizarre looking. But that was a tough one. Okay, so next, okay. This one's also not so clear cut. Anybody willing? Akanksha, are you there?
Hello, Dr. Westerman, I'm here.
All right, this one's for you then.
Almost looks like a sinus tac.
Okay. Well, this is, I think I have one of, no, I don't. Well,
I just wanted to add to that, the end of QRS looks a little slurred, so maybe some pre-excitation.
The end of QRS on this one? Is that what you're saying?
Mm-hmm.
So pre-excitation is going to be manifest. The delta wave will be at the onset of the QRS.
Onset, right.
Because it's the onset of ventricular activation that's coming from the accessory pathway. Okay. But I do agree that the terminal portion, it looks like there's something else there. So be careful when you're labeling something like this sinus tachycardia. The P waves certainly don't look normal axis. They're not very clear in 1 and 2. They're not upright if you're seeing them at all, maybe flat. So I would be wary about just calling this sinus tachycardia. But can you clearly see the P waves?
No, it seems like it could be flutter.
Yeah, so this one, you can't see them well. The guy's in it, he came in this, he's got some mild decompensated heart failure that's new for him. and you're not seeing anything discrete, this would be a good one to give adenosine to and see what's going on. If it is atrial flutter, whoever answered that, do you think that this is what we call typical atrial flutter or right macro reentrant isthmus dependent flutter?
It doesn't look very typical. Let's put it this way.
I would agree. So typical, you see the sawtooth pattern in the inferior leads, especially. I can't make out really much of anything. If you caliper it out, then these P waves march. And so this is a 2-to-1 rhythm. The atrial rate is pretty fast, about 300. We would classify this as an atrial flutter, but I agree it doesn't look typical. And in fact, this was a left atrial flutter in somebody who has no known history of any kind of heart disease, no prior surgeries or prior ablation. So a little bit unusual to present like this. But this is one where it's hard to see. Adenosine could help. And this is a 2-to-1 rhythm and a left-sided atrial flutter. So not all atrial flutters are going to give you that pretty textbook case, but this is another flutter. And it's hard to make out what's P wave here. This one ended up being typical flutter, but this is a woman who had just undergone surgery. And so the flutters can look all different ways, and sometimes they're clearly typical and sometimes they're clearly not typical. And then like this one, which was typical, doesn't necessarily look all that normal. Okay. I just have a couple more that I'll take you guys through and just examples of what things can look like and how having a baseline EKG can really help. So this is a congenital patient. This is her baseline EKG. And when we look at this, if we flip back to the tachycardia, even though it's wide complex, it's exactly the same morphology as her baseline. You might tell me that, well, the inferior leads look different, but let's ignore that for a second. I don't know why they would look, maybe no, I think it's the same person. Certainly the precordial leads look exactly the same. She had, this is an atrial tachycardia. You can't really see P waves, and so the clinical context can help us. Congenital patients often have atrial tachycardias and what we call atrial reentrant tachycardia. So they're little micro reentrant tachycardias, not automaticity in general, related to prior scar lines. So that's an example of an AT. This is another example of when the baseline really helps. So this is a guy who came into clinic. And, you know, he's got a wide QRS, but it's the same as his baseline. This is his sinus rhythm, or as close to sinus as we could get. And there's just no P waves, and it's hard to discern what's going on. So I'll use all the clues, and I'll look at, anytime I see a funny blip at the terminal portion of the QRS, I'll focus on those leads in the sinus one. So there's something here in 2, there's something in V5, V6. So we got one when he was in sinus, not that you can see 2 very well here, but V5 and V6 doesn't have that thing. Maybe there's one here, but when it's clearly a sinus beat, there's nothing there. So this is a guy who has what I think is ABNRT. We're actually gonna bring him to the lab today. But sometimes it's not clear, but you have to be really careful about labeling things sinus tachycardia if you're not really seeing what's going on. And the reason I think that it's AVNRT is this is what his pacemaker is doing. And this is the atrial channel, this is a ventricular channel, and you've got that V and A, and that V and A relationship is what we have hit on before with AVNRT, where it's being activated simultaneously or in parallel. And so it could be VT, but it looks the same as his sinus. So I know it's not ventricular. And it's very hard to imagine another way that you're getting this really short VA time or short RP. It could be an atrial tachycardia with a long first degree block, but there's some other suggestions in the EKG that would tell me that's not the case. Like here, he's got a PAC coming in, and then I think that's a retrograde P there. So, all right. And then the one thing that somebody before talked about aberrant conduction. So I'll show for when you get wide complex tachycardia, there's a lot of different criteria for distinguishing the SVT from VT. And so just some sort of broader things without having to go through criteria is, what does it look like? Does it look bizarre, or does it look like normal classic left bundle or right bundle? How wide is it? And then the ones that we always look for, AV dissociation, for example. And then clinical history is really critical. So person with coronary disease, prior infarct, they come in a wide complex tachycardia. I don't think you need to pull out your, your notes on different criteria. This is somebody who you would be, this is VT until proven otherwise. And in his case, you see AV dissociation. Another one, 63-year-old man with prior MI and dizziness. This is a man who has a narrow QRS, and then he's on the treadmill and he has this. And so this is, I think it's just rate-related aberrancy, just sinus tachycardia. But look, this is a pretty normal looking left bundle morphology. So this is aberrant conduction rather than, if you were to just see this EKG, rather than VT, because it just widens like a normal left bundle would look. And then we've seen that one already. We won't do that one. Okay, that's all. Do you guys have any questions about anything? So I guess clinically, when you're looking at EKGs, that short RP tachycardia, especially when it's at the end of the QRS, that's most likely AVNRT, related to how the ventricle and the atrium are being activated. And then the mid RP tachycardias, think WPW or AT, depending on the patient's clinical age and the clinical scenario. And always call if you need help. All right, I will stop sharing. Have a good day, everyone.
The preceding program is copyrighted by Emory University.